we've transitioned back to local reporting recently because, it's not a sustainable thing to be day to day managing all IPs in a 14 hospital system from my angle. But that culture improvement is moving onward, though, and we're still sustaining some of our improvements. And I think that's really helped quite a bit. We're still seeing transparency from the local facilities that we didn't see before, more than we ever have seen before anyway.
Infection stops where information starts. Welcome to the Transmission Control Podcast, where knowledge is your strongest defense. Broadcasting from the front lines of healthcare, we dive into the strategies, science, and stories shaping infection prevention today. Each episode, we connect you with experts on real-world insights to help you stop the spread of healthcare-associated infections, protect patients, and strengthen your practices as an infection prevention and public health expert. When the right information reaches the right people, lives are saved.
Hello and welcome. My name is Garrett Hollembeak, Editor-in-Chief of Transmission Control. I'm joined here today by Hank Balch. And today we are talking with James Hensley, AVP of Appalachian Regional Healthcare, to get his insights on public health, exceptional collaboration with your public health department, and a wonderful term that we learned called radical candor. So we are going to get into it after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome to the Transmission Control Podcast. My name is Garrett Hollembeak, Infection Preventionist and Editor-in-Chief of Transmission Control. I'm joined today with my co-host Hank Balch. Hank, how are you doing today?
I'm doing great, Garrett. Really looking forward to this interview. We're going to have a lot of fun today.
Yeah, I'm excited. And the reason I'm excited is because we're talking about this whole season is focused on the IP orientation. When you're a new IP and you're just getting your feet on the ground. And one of the most helpful and most frightening things about a new IP is how do we interact with the public health system? So whether it's your county official or your city health department, what's the right way to go about interacting with them? So to help us learn more about that, we're talking today with James Hensley, AVP of Appalachian Regional Healthcare System. James, welcome.
Hey, appreciate it. Thank you for having me on.
Yeah, we're excited. Now, this is not necessarily IP related, but I say it Appalachian. But what's the right way to say that?
Oh, it's definitely Appalachian. So,
okay, it's Appalachian.
When someone says Appalachia, well, that's what you know.
Yeah, that's the debate, though. I mean, that's a live debate. That's just not like a one-off. Like, there's people that go to fisticuffs over that. So it's
for sure.
Important.
Yeah. Oh, good. Now that we got that squared away from a source of authority, James, can you introduce yourself and tell us a little bit about you?
Yeah, as mentioned, I'm the AVP of Infection Prevention for Appalachian Regional Healthcare. Been there for right around 8 years. We have 14 hospitals, both acute care, critical access, LTAC, skilled nursing facilities. We got the whole spectrum for infection prevention work. Background, I'm actually from the laboratory of microbiology and clinical lab, which differs from some of the classical pathway for infection prevention. So I have that specific background to work with and work from. But glad to be on the podcast.
Yeah, well, thanks for joining us, and we like to hear that. IP is such a wide space that we love it when people come from lab, pharmacy background. I myself come from a sterile processing background. So we like to hear those alternative roles coming into the world of IP. Now, is there anything special with that background that you focus on that maybe you catch or notice that other people from other backgrounds may skip over?
I use that quite a bit, especially in the last few years in our organization where we've seen an increase, from the community coming in, highly resistant organisms, using that background to really educate and speak from that point of expertise makes it very easy for me to do that, especially with providers and our upper level clinical folks. They really prefer that sort of high specificity and detail whenever they're receiving information about these outbreaks of these organisms. So,
did you know that you wanted to go into IP when you were in lab, or is that something that kind of grew out over time?
Oh, actually, no.
I grew out over time.
Yeah, I see.
Nice.
Pun intended. But, I actually had no idea that this was a direction I wanted to go. I worked as a, frontline laboratory scientist and eventually was a laboratory supervisor and kind of got into the micro world. And that's really what kind of instigated my love for transitioning into IP, especially as infection prevention. Some of the facilities I worked at began to work more frequently and in more detail with the microbiology lab. I kind of got into that thinking, hey, there's something here. There's more to just, identifying, which is critical. Accuracy and identification is critical. We all know that. But, anybody that really is a ongoing, continuous learner like myself and is really interested in problem solving and having new issues to address on a day-to-day basis while still applying that micro background and interest level is a great opportunity for me.
That's awesome. So if you're working in the lab right now and listening to this podcast, there's a whole wide world of IP out there that you would be perfect for.
Absolutely. We need lab people. That's the thing. We always want diversity in your IP department, especially as a system. We found that with 14 facilities, we've had people from many different backgrounds, and that really allows us to have that multidisciplinary, multi-expertise, and we allow people to really explore that background. At least in my program, we do, and it really benefits us in the long run.
I like that a lot. That's really important. Now, getting into the meat of the topic today, what is the reason or what's the thought process or the concern behind IP, especially when you're new, calling up the public health department and saying, hey, I need some help here?
Yeah. That's always a scary one, right? And I can speak from experience. My first few years as an IP, I started off in a facility where I was the only IP and I had zero experience. That's an interesting spot to be in where you didn't have the person that was present. They retired before I was hired. So I was learning kind of from the hip almost on the fly. And, so when I reached out to public health and they, to get some information from them, there's a lot of stress there, right? I mean, that's the nature of it. You're thinking, am I going to get in trouble for this? Is my facility going to be unhappy with me? Are the administrative team at my local facility going to be accepting of that feedback? But, one thing that is a misperception, at least for a new IP, is that public health is punitive. They're really not a punitive organization or body. They don't really have that authority, and they're not really interested in that. It's really an altruistic and positive frame of mind that at least with our public health team that I interacted with, that was really the key, is that, the stress was there, but as soon as I met with them and really understood what their goal and intent was, it completely eliminated that for me.
I would assume, James, it's probably a good idea to be proactive in getting to know that health department, right? So that it's not, you're introducing yourself on your terms, not the other way around, and that they're having to call you about an issue that, this bridge of collaboration that we're going to be talking about today wasn't built. So, I mean, is it like you send cookies on your first day, or like, what's that first soft step that you would encourage IPs to take there?
Just reaching out to your local health department, inviting them in to have a discussion or at least a call or a conference call with your team. Not a site visit or an audit, but really just right. You want to establish a rapport and a relationship because it's bidirectional. Their communication with you benefits them just as much as it benefits you from a knowledge perspective, because they need to know what's going on in your facilities, and you guys really need to have that positive bidirectional communication going on.
Yeah, I like that a lot because, as much as we tell staff members when we're rounding or we're doing device audits, like, we're not here to get anybody in trouble. We're here to educate. And then somehow we forget all that when it's time to call, the local health department, and we think they're going to get on our case about anything going on in our facility. So I think that's an important reminder. Now, what are some situations that the IP on the site, whether they're part of a system or they're kind of out there by themselves, when do they need to reach out to public health?
Realistically, if you go online, you're using your standard resources, like you're looking at your CDC guidance and you need clarification, that's a critical opportunity because they can offer that clarity or a practical example or more detail specifically, or if you have organisms that you're not familiar with or unique situations, anything you see that looks high risk or it's on a the naughty list, the CDC's, high risk pathogen list, anything like that, always important to reach out to public health on. But realistically, it's anything that you're unaware of what to do next because they can really give you some great feedback on that.
James, one of the conversations we've had on the other podcasts that we do on these platforms is an example. We did an episode on surgeons. Actually, we did a series on surgeons. And the big takeaway was surgeons are people too. The real people, they can be scary sometimes to approach. Same thing that we're talking about with the public health officials. But obviously, these are human beings on the other side of the call or the email that you're reaching out to public health to ask these questions, get clarification. I know you talked about your background getting into the IP side. Are you aware of the requirements or the kinds of people that take these public health roles that you would be calling? Like, are these just IPs just like the rest of us that are calling and helping us, or are they taking different career paths to get to where they are?
Well, yeah, it really depends on your state and your health department, right? So like in Kentucky, where I was interacting with the majority of my time with public health, we had multidisciplinary public health officials in HAI prevention roles. We had people with nursing backgrounds, emergency room, we had ID physicians, pharmacists. So we really have the whole gamut there. So I was unaware of that entirely as a new IP, right? Like I did not know who I was talking to, what their background was, and what they could do to me, right? That last part's a big one. When you're new to a role, you're looking at that 90-day eval, right? Am I calling public health and getting us all in trouble? That, which is certainly not the case, but it goes through your head.
I think that really does. And I know that when I was a new IP, TB was one of the worst things that, like any suspected case or we had a weird test. And so our local TB guy, and that's maybe something that new IPs may not be aware of too, is that public health departments can be very specialized. So you may have, this is who you call about TB. This is who you call about STI. This is, maternal and fetal health too. So what's the value of that specialization that the public health apparatus can offer that maybe we don't have in-house?
No one can be an expert in every single component of the field, right? I mean, you're talking about STIs. You're talking about, MDROs, you're talking about TB. There's a lot of specifics associated with those things and their prevention, as well as the best practice guidance for how to approach it and your state requirements. And those individuals are more than equipped, and they're experts in that and can give you that feedback to help you be successful.
I like that a lot. Is there any time where we can share too much information with public health folks?
Good question.
Well, I'm actually kind of in a funny spot with that because, with my interactions with public health, I mean, I kind of approached the whole thing from the angle of radical candor, right? Like I tell them like it is, right? And I trained my IPs to be transparent in that way. And, we found so much more benefit from just discussing the issues and depicting them as they are instead of trying to make it seem, quote unquote, less bad, because every organization that a public health official or a auditor goes into is going to find issues. I mean, there's no one walking around with a perfect facility. It doesn't really matter where you go. To hide an issue or to make it seem less significant than it is, or just to omit something, that you might be able to get assistance with, it really doesn't benefit you or them in the long run, because ultimately they're either going to find it through a walkthrough, or you're going to have an outbreak and it's going to be found that way because you're going to be, begging for mercy from everyone. Because if you've ever worked an outbreak, you know that you are there working long hours and many days. So I really think that, being very open and clear, and of course, establishing that knowledge with your administrative team ahead of time that you're going to be that way. I think that's very important. You don't want to surprise, a CEO or a CNO who's unaware of that's your approach, and making sure they're fine with that. I don't want to get anybody in trouble in that way, but I do think that anybody stands to benefit in the long run from that sort of approach, because that's what we did. And we really, I don't think there was ever a question as to whether or not we were being clear about the issues that were to be identified or they hadn't even seen yet. So we were working on those things ahead of time before they were even on site to do walkthroughs. So
Public health obviously has a component of a political nature to the department, right? These are government officials. Outside of just the governmental side of politics, there's a little bit of, facility politics that you alluded to, right? Of, hey, I need to make sure my administrators know how we're messaging this, if you want to use that language. To Garrett's point too, like to his question, right? Do we just offer all of this stuff out and say, hey, ask me any question about anything? Are we specific about the specific problems and gaps that we're trying to get help with or get support from, to your point, James? And there's a line there that, especially as a new IP who maybe has not had to have these kinds of external political conversations or, marketing type conversations, right? Is the marketing department going to come back and be like, so why did you just announce to the public health department that we've got this issue that we are not even aware of or haven't vetted, right? How would you encourage these new IPs again to learn the messaging skills before they make the faux pas they have to go back to their administrators and apologize for?
Sure, that's a complex question. I think you have to, your environment, right? Each organization has a different culture. And I think at the beginning of your time as a new IP, especially if you don't have any other IPs in your facility or any experienced leaders in your department, you're having to really learn and understand what your organizational culture and environment is. You have to react accordingly, as of course. We all know that you have to have some degree of self-preservation, right? But, for me, my original goal, and I've always been this way in any role that I've been in, I'm always looking to set the expectation, that as an IP, my goal is patient safety. And, when I work with public health, I always told my leaders, that we're setting the expectation that this relationship is non-threatening and patient-centered. To harm an organization in some way doesn't benefit the patient in the long run. That's not to benefit public health either, right? So from my perspective, we were able to establish that with our public health officials, and they came with that information too, though. They showed up and said, hey, we're all about, improving patient safety and quality here at your organization. We're here to help you in any way that we can. And I chose to take them at face value because that's what I wanted for the organization. That's what my leaders wanted. That was a great, lock and key sort of fit. So, my environment was ready for that sort of approach.
Not to get us off track, right? But to move up to that IP leadership, or maybe the administrators that would be involved in hiring new IPs, your point about the culture piece is critical. Are you interviewing this IP not just for the background, not just for skill set, but does this IP's cultural understanding of our organization and how we're going to approach the patient-centered, non-threatening approach with public health? Or have they been in their background, right? They may have had experiences that have been very negative around data sharing, around public health, around transparency. And for whatever reason, that's the culture that they're bringing with them. Oh man, it seems very important to identify that in the interview process for IPs and to message exactly what you're talking about. That's not how we're going to operate here.
No, you're making a really good point there. I've interviewed a number of IPs, and I can tell you that there are times where I've interviewed people and said, hey, that's a really good IP, maybe not for this organization, though. And it's not a knock on them as a person or in their professional skill set. It's just, culture fit matters, and your background matters, and how you want to approach the job matters with whether or not you're going to be successful. And to optimize those hires and those individuals, you're right, you got to know those things in the interview.
That's 100% true. The culture will define. We all know what to do as IPs. We'll learn those skills, the hard skills and the soft skills. But culture, that's got to be embedded. And it's a whole lot easier if it's clear from the beginning. Now, I like the term that you used. Did you say radical candor?
Yeah.
I love it. We're going to come back to that because that's such a great concept. And you as a leader, I imagine that, and I would guess that since your team knows that that's your approach, that approach trickles down to your site IPs as well.
It does, yeah. And we actually, restructured our infection prevention department a couple of years ago as a temporary restructure post-pandemic, and it was really the goal was to systemize and have them all report to me directly, at least for a year or so, as we get back on track. Everybody knows, post-pandemic, there was a lot of degradation of skills for a number of totally valid reasons and difficulties in healthcare. But we really wanted to really establish that daily direct line of communication, with my IPs. I told them, I support you. I'm going to back you up. If you are approaching this from a patient safety perspective and you're identifying issues, bring them to me if they're not getting addressed at your facility, right? And that was actually one of the things that really helped us be hugely successful in the last couple of years with some of our infection rate reductions. We're down 80+% in device-associated infections. We had our first system-wide quarter with with zero C. diff hospital onset cases recently. And a lot of my IPs would tell me it's because that they felt that they had support from the upper level administrative as a system. So it's a bad joke that James said, or I asked James and James said this. Went on at my organization for a while there, but we've transitioned back to local reporting recently because, it's not a sustainable thing to be day to day managing all IPs in a 14 hospital system from my angle. But that culture improvement is moving onward though, and we're still sustaining some of our improvements. And I think that's really helped quite a bit. We're still seeing transparency from the local facilities that we didn't see before, more than we ever have seen before anyway.
I love it. That's the testament of a good, sustainable system is that you can set it up, you can build the culture, and then even when the details change, the organizational structure changes, that culture stays the same. Now, we all want successful interactions, successful projects, or collaboration with public health. Can you share an experience or a time that you've had really good work and collaboration with public health?
Absolutely. So I was a 2-year IP. I get a phone call from public health, and what they say to me is they say, well, I know that you're stressed out because we're calling you, and we don't call you unless we have something to say. So we want to tell you have a novel mechanism of resistance in your facility. When you're looking at true carbapenemase production, you're looking at mechanisms of resistance. We had Acinetobacter baumannii that had, OXA23 as its mechanism of resistance. So it's a true carbapenemase producer. It has the ability to transmit that via plasmid and increase resistance in your community in general, and other organisms as well, not just, other Acinetobacters, right? And because of that, it's considered a high concern pathogen. There, it's explained to me. So first thing they tell me is, hey, you got a lot of things you got to do, and there's a lot of new things you got to do. But we're here to help you, and we're going to walk you right through this process, and we'll also come on site and help you kind of establish some of this. And they had a ton of resources available. They had us do point-prevalence studies, looking at each affected unit, looking for, colonization transmission. So we're seeing if our interventions are working. And they had all the resources, education materials for staff. They had the ordering forms and how to collect the swabs, because if these are swabs that you don't normally collect, you might want to have a specific education for that for your staff so you're being accurate. So really, they were there and present and had all the tools to kind of put me at ease to where I was able to do the work, which was the critical need at the time. Is, we needed somebody to be present, delivering information. Instead of taking 48 hours to develop an education and get everything implemented and approved, we already had it approved and stamped public health education, right? And processes. Well, I was able to get boots on the ground faster because they were present and helpful. So, I could go on about that for a long time because we have more than one incident. It's been an ongoing community issue over the years. And, our efforts with public health have led to a rate reduction in our whole community across Eastern Kentucky for this Acinetobacter, where, it had made its way into nursing homes and all that. And so, these pathogen amplifier centers like that have kept it kind of present. But when it comes to outbreaks and transmissions, we've developed processes through working with public health effectively and successfully that allowed us to be successful going forward for many years now. We don't see outbreaks like that anymore. Knock on wood, hey, tomorrow. But if it happens tomorrow, we know we're equipped to deal with it, and we know we have done it before. So we have the team that would help us address it.
James, like we talked about at the beginning of the interview, obviously if there's a new IP that's coming in with no existing IP structure around them, like the solo IP, or even if it's a new IP, like an experienced IP coming in just from out of state who doesn't know this public health setup, is there like, have you seen IPs calling around the region to each other and saying, hey, I'm new, I don't know the health department, who on this list of 20 different niche health department people do I need to call for X, Y, and Z? Like, is that a live skill set? Is that something that you would recommend either like brand new IP newbies or, just out of state to say, call around, let's get this network going and then start those soft reach outs that we were discussing earlier?
Yeah. And I think that, a new IP, you're going to want to reach out local APIC. If you have an APIC organization, they can help you out and increase that networking ability, because you should have a local APIC chapter that you can meet other individuals who can. And that's one thing I've learned about IPs is that they're always willing to help. I mean, I've never asked an IP for assistance and they not give me more than I asked for back. I think that's the same with the public health teams that we worked with. It's that same sort of shared mentality, because I always say that an IP is the public health inside the hospital, right? That's the reason why we work so well with them directly. They serve as the external body for the exact same goal. Yeah, that's a great opportunity. Go reach out to your APIC organizations. If you have a system, reaching out to other IPs in your system is another great option as well. Something that we had done in our region with this original Acinetobacter outbreak is that we actually started a regional collaborative for HAI prevention and antimicrobial resistance. So that was an organization that all new IPs would get brought into. They had quarterly meetings, and they really kind of set the tone for what the objectives are from a public health and HAI prevention perspective are regionally, and directly gave that forum an opportunity for communication as well to be established, even without having to reach out directly by phone, which not everyone is willing to do.
I love it. I think it's appropriate. Your lab background is showing, because a lot of what we hit on is culture. That's a pun very much intended.
Yeah. I got it.
So James, this is excellent information. And I think any IP out there, 10 days in the field or 10 years, has some really actionable takeaways from this. Can you give us a couple, maybe 2 or 3 go and do's to build a good culture for an IP with their public health folks?
Sure. Yeah, I can. And I mentioned this earlier. I think it's a big deal that, through your interactions at the beginning, wanting to set that expectation that it's patient-centered, non-threatening, non-punitive, huge deal. I think identifying shared goals, right? I mean, you're working with public health, and like I said, you're the public health inside the hospital. They're the external entity. You guys are on the same page. You're going to have shared goals, because each state has different issues. With like say we're not hugely impacted by Candida auris today in Kentucky, but there are states that's a huge focus. And identifying the shared goals of CRS prevention. Are you screening at points of entry? Is that a directive from your local public health entity? They can give you that kind of information. But I think it's critical too, that once you establish that sort of collaborative relationship, you recognize that there's going to be a lot of possibilities and future benefits that'll have a measurable sort of positive impact. That's generally speaking kind of the thought process from my end anyway.
That is great. And I think very important reminders and really good takeaways that we can go and do and have a good participative, patient-centered dynamic with our public health friends. So James, I want to thank you for joining us today and all of the expertise you've shared, all of the insights. And I think we need to have you back on to talk about your C. diff prevention, because that's I think any facility would give their left arm to have. You said you went a whole year as a system with NACVI?
As of recently, we had a whole quarter for the first time. It's 14 hospitals and 2 LTACs. And
that's amazing.
0. And so we've seen a huge reduction over the past couple of years. We're looking at around 70 to 80% reduction over the last 2 years, and we're maintaining that. So,
yeah, I agree. That's definitely worth an episode.
Hey, I'll take it. I'll come back on.
Okay.
I always like to talk about the good stuff we're doing, right?
Amen.
So, and if I can help anybody else while I'm at it, even better.
Awesome. All right. Well, James, we'll get you back on soon, and thank you so much for joining us today. Well, hang Hank, like we were saying, I think we may need to bring James back on for a whole episode 2, not only on the CDI reduction that they've had, but I kept writing the word culture down. I love that concept of radical candor with your public health officials. And, James coming from a leadership position, I think there's clearly been a huge impact in his whole system about that approach with public health.
It was interesting, Garrett, too. His radical candor didn't just go toward public health. It went to his administrators, and that was one of my takeaways as well. Oh, man, I'd love to talk more about how to be brutally honest with your administrators and how you're communicating some of the challenges at the system level, but then also how you're going to be not only with public health, if it's your Joint Commission surveyors, your DMV surveyors, there's a lot of areas that if you're forward in that culture that came up again and again, I do believe that is a winning strategy, much better strategy than trying to not necessarily hide things, but just not offer everything. But like James called out, if you're holding anything back, then all those resources that public health has, they don't exactly know where to deploy their help because they don't know the full story. Now, clearly that's not a long-term strategy. It may work, one-off, but then he said eventually the outbreak is going to come back and bite you in the butt anyway, so you might as well just be honest from the very beginning.
Yep, 100% agree. And you know what? The germs don't care. They don't care who finds the issue or who solves the issue. We just got to make sure we're keeping our patients safe. So I want to thank James Hensley for joining us today, and thanks Hank Balch for hopping on today. We're excited to have you. And to our audience members, stay tuned. We have a whole season lined up of great guests, great insights. And remember, infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.